catheter. This is the very important artery on the front of the heart called the left anterior descending. I'll play that for you again. And there's major plaque and major narrowing at this level and then again down here right at that branch point. So that's a person who's having unstable chest pain and is on the verge of having a heart attack. What do we do about that? We put a couple of wires down the different branches and we deploy balloons or stents inside the artery. A stent is a wire coil. Looks a little bit like the spring in a ballpoint pen. It's mounted on a balloon, and the technique of stenting is that, again, that we pass guide wires down the artery. The stent mounted on the balloon is passed down to where the blockage is, and the balloon is used to deploy the stent. So here's a stent being deployed in the artery on the front wall of this individual's heart. Another stent put a little further down across that branch point. And here's the final result. So that's an example of acute coronary syndrome that was treated with coronary stenting. Now, what does a heart attack look like? In our language, a heart attack is sometimes called an MI, myocardial infarction. You see the word STEMI. That refers to how the EKG looks in a certain type of severe heart attack. And so what does that look like in the cath lab? It looks like a large branch has been lopped off the coronary tree. So here's my catheter. Here's the big artery on the front of this person's heart. And what they have had, they've had plaque rupture and clot formation in the artery on the front of the heart. So this coronary artery has gone from being only mildly narrowed to being completely blocked up. And the muscle on the heart muscle on the front of this person's heart is in the process of dying. That's what a heart attack is. We were able to get a wire down the artery, and that's a stent being deployed at the area of blockage. And that's the result. The artery is opened back up and heart muscle is saved. Yes, sir?
That happens to me in my apartment before I get to the hospital. How much time do I?
Our goal these days is to have that artery opened within 90 minutes of your first medical contact. And St. Anthony's and other hospitals in the area have finely tuned mechanisms to try to make sure that that's done.
So you're okay as long as you get there before 90 days?
Well, heart attack's always dangerous. And the reason a heart attack can be dangerous, like a person who's in that state is at risk of losing their heart rhythm altogether. And that's what is called sudden cardiac death, and that is a known complication. So the reason we want to get these arteries open as soon as possible is to preserve heart muscle. Once heart muscle dies with a heart attack, it doesn't regrow. It's gone forever. It'll be replaced by scar tissue, and the heart will be weakened as a pump. The other reason to get things done quickly is to prevent the kind of lethal complications of a person losing their heart rhythm altogether. Good question. Thank you. So we've seen some examples of unstable coronary disease. I think a lot of people don't realize how much healing capacity the heart has. And I want to talk about two major mechanisms by which the heart heals itself. I love this quote from Ernest Hemingway. The world breaks everyone, and afterwards many are strong in the broken places. So an initial diagnosis of heart disease doesn't mean your life is over at all. Let's talk about the mechanism of collateral circulation. Collaterals, in my language, are secondary or accessory blood vessels, which can develop in a variable and individualized manner in response to decreased or interrupted blood flow. That's a complicated sentence, but what it means is that the heart can grow new blood vessels, and I'm going to show you an example of that. People do vary widely in their ability to develop them. Exercise is a proven way to do it, and when gene therapy gets a little further along, now that we've decoded our DNA sequences, the guys back in the basic science labs are working on ways to develop medicines which will stimulate the heart to do that. So what does a collateral look like? This is a right coronary artery that's completely blocked up. So this is my catheter right here. Somebody has previously placed a stent right at the mouth of that artery. That stent has gone on to be completely blocked up. So this right coronary artery should be a big artery that swings down here and serves the bottom part of the heart. It's completely blocked up. Now if we take a catheter and we put it in the other coronary artery over on the left-hand side of the heart, this is what we see for this patient. There's the catheter. Here are the two arteries on the left-hand side of the heart. And look what's happened here. I'm going to play it for you again a couple of times. The artery on the front of the heart has grown down and connected to the right coronary artery. So here is this person's right coronary artery filling backwards from the other two arteries on the heart. This is a rather dramatic example of collateral formation inside the heart. Everybody with me on that one? This is like an auto bypass. This person has bypassed their right coronary on their own via collateral blood flow. I have another angle of it here. So here's my catheter. Here's the artery on the front of the heart. It's grown down around and physically connected to the right coronary, filling it backwards. Sir?
What is the length of time that it takes for that to grow?
The stimulus for it to grow is heart muscle that's not getting enough blood flow. So if somebody does have, in the example of the heart attack we saw, where the artery suddenly becomes completely blocked up, that person's not going to have collaterals. Or if they do, they'll be very small. If the coronary disease has progressed gradually and heart muscle gets starved for blood flow, that is the stimulus for the heart muscle to make the chemicals that signal the need for collateral formation. So the slower the heart disease comes on, the better, the more favorable it is in terms of collateral formation. Excellent question. That's, you guys are getting it right away. That's good. So that's collateral formation. Sir?
Is there a test in all of this series that we read in the newspaper? We're attending here at St. Anthony's and other places. Some were saying that there was tests that can be given or can be done to evaluate what the person's current state of affairs is inside.
Right.
So is there a test right now that can be done, and should we do these tests?
If a person has no symptoms and their risk factors are under control, then the answer is no, because it's not going to, if you believe in the 50-50 rule, if you live to be 50, you have a 50-50 chance of this anyway, then my argument is you already know what you need to be doing for prevention. And we're going to talk about diet and exercise as prevention. What are the options for working this up? Well, traditionally a stress test is a good starting place. These days, the CT is competing with that to a certain extent. They give complementary sorts of information. But for if a person has a lot of risk factors, it's a male over 45 with 2 or more risk factors, or a female over 55 with 2 or more risk factors who say wants to get into an exercise program, that's the kind of person that should take a stress test. But for most asymptomatic people, we don't recommend screening testing for coronary disease.
You recognize the major symptoms, the chest pain and that kind of thing. Are there any subtle symptoms that may come on 2 or 3 years before we have a heart attack that we should be aware of?
All of us have been living inside our own bodies for all our lives. I think we know them better than anybody else. So if you have symptoms that you think might be your heart, it's definitely worthwhile getting checked out.
I went to your St. Anthony's EKG check last week, and they found a right branch blockage.
Right.
And so I went to my regular doctor, and he pulled up a past EKG stress test, and it was been there for some time. Can exercise fix that, or is that something that'll just always be there?
The EKG that we've all had is the electrical signature of the heart. So that is the heartbeat is driven electrically, and that's what the EKG is. It's one of the oldest tests that we have. It's completely safe, and we get a lot of clues. We can get a lot of interpretation about that. But God didn't create the EKG to be a perfect tool. That's why we have these other things, the stress test and the catheterization and so forth. The right bundle branch block that you have is like a little electrical short circuit in the wiring of your heart, and it can easily exist in isolation. You might have a completely normal heart otherwise, and if your doctor has proven it was there years ago, then it is a finding rather than a disease.
Yes, ma'am.
In a woman having a heart attack, is it possible that you just feel an electrical current go through that side of your chest?
The symptoms of heart disease in women can be significantly more subtle than in men. So that sounds reasonable. That sounds reasonable.
When you go for a stress test, other than the walking on the treadmill, they also take nuclear pictures.
Right.
Will that show blockages?
It looks at the heart from a different angle. With the nuclear images, what they're doing is imaging the heart muscle. So when you walked on the treadmill, they made an injection of the tracer. That tracer goes wherever the blood flow goes on your heart. So when you lay under the camera, they're actually imaging the heart muscle. And any muscle that's getting good blood flow is going to get the tracer. If we see a nice, uniform, even picture of the entire heart muscle, then we know there's good blood flow everywhere. And let me just finish that question. Say this fella with the completely blocked up right coronary artery, then if he took a nuclear stress test, there would be a defect on the inferior wall of his heart. Even though these collaterals are here, we'd see a little defect in the muscle down there on the nuclear images. Do you see what I mean?
Yeah. I have 2 stents myself. That's why I'm asking this question. And one time I went and they didn't, the one of the stents that was in already was blocked. So they went in and ballooned.
And did they find out that you needed to have the catheterization with the nuclear stress test? Is that the sequence of events?
I've had catheterization twice. Like I said, I had 2 stents.
So your abnormal stress test led to a catheterization where they opened up one of the stents. Is that right? Yeah. And the reason that we follow people with nuclear stress tests as opposed to doing serial cardiac caths on them is because of the safety issue. You're accepting, anytime a person comes into the cath lab, they are accepting a risk of complications. We don't get them very often, but anybody that does it for a living, there's no cardiologist around that's never had a complication from a heart cath. So you want to have a good reason to wind up in the cath lab.
What, sir, is the relationship between a heart attack and a stroke, so-called stroke?
It's the same basic process of hardening of the arteries. If the arteries are on the heart and some of the heart muscle dies for lack of blood flow, that's a heart attack. If you had a stroke, there's 3 basic mechanisms of having a stroke. Number 1 is you can form a blood clot inside your heart and throw it up to your brain. It breaks loose. That's most commonly associated with abnormal heart rhythms. So if you've not been checked for abnormal heart rhythms, you should be. The second mechanism is blockages in the carotid arteries here in the neck, and it sounds like they checked you for that. The third mechanism is it's a local problem in the brain, that a small blood vessel just clots in the brain, and that's usually a consequence of hypertension. So those are the 3 basic mechanisms of having a stroke, and if you've had one, you ought to be evaluated for all 3. Anybody that's got hardening of the arteries in the brain, on a statistical basis, has a chance of having it on the heart. So if you've not been checked for coronary disease, I think you should be.
You know what the doctor told me, the cardiologist, when I went to see him? Well, he said, you're 85 years of age, and whatever you've been doing, continue to do it.
Well, I don't want to speak ill of anybody, but I think your presence here at our talk indicates you might want to get a second opinion. Does that answer your 3 basic mechanisms? Throwing a blood clot from the heart, blockages in the neck, or a local problem in the brain.
But they did this and they said they were all right.
Yeah, so that one's off the table. It's got to be one of the other 2. Yeah. So I'm on healing mechanisms of the heart, and we've talked about collateral blood flow. The second mechanism is something called positive remodeling.